Excellent. Well, hello, everyone. Thank you all for coming. Super excited. We have Vigorous Steve here today. He doesn't need any introduction, but he's a science-based content creator, bodybuilder, coach, entrepreneur, author of multiple ebooks, and cat lovers. So he's going to be presenting to us today. If you guys have any questions, just drop them in the Q&A in the chat, and I'll get to them at the end. And without further ado, Vigorous Steve.
What's up, guys? Thanks for joining the Merrick Health webinar. I'm going to start sharing my screen because we have a lot of slides. And of course, slides is what keeps the show rolling. So let me open this up here. Hopefully you can see this all. It's called Secrets of Health Optimization. It's a collaboration between me and Merrick Health. For the next 50 minutes or so, we're going to go over all things related to health optimization, mostly from a male health optimization perspective. Let me first explain who I am. For the guys that don't know me, I was an 11-year drug-free bodybuilder. So from the age of 15 years old to about 26 years old, I was purely bodybuilding without any performance-enhancing drugs. Then when I was 26 years old, I decided to take the plunge after so many years of doing research online and never really felt ready. And back then, we didn't really have hormone replacement therapy. All we had was steroid cycles. So after I took the plunge, I took performance-enhancing drugs at various dosages for about 14 years. And now for the last year, I've been cruising, quote unquote, cruising on HCG monotherapy to restore testicular function and get my wife pregnant. But more on that later. I have a Bachelor of Information Engineering at the University of Amsterdam. When I was 21 years old to about 26 years old, I was a financial business consultant, which was very, very interesting. A good time of my life until the economic crisis of 2008, 2009, and 2010 hit. During that time, I traveled through Asia, Southeast Asia mostly, but also China, Mongolia, and other parts of Asia for an entire year. It was eye-opening. After that, or before that time, I already came to Thailand. But after that year of backpacking, I decided to move to Thailand, where I've been living for, well, I think since, let's say 2013 full time. So that's the last 11 years. I've been a bodybuilding coach for about 12 to 13 years. I'm now retired because I'm a full-time YouTuber. Apparently, that's a profession nowadays. And I make a lot of YouTube videos. I mean, most of you guys remember me from my YouTube channel. I was a presenter at Swiss Symposium, which was always a lifetime goal. This is where I met a lot of the team from Merrick Health, Stephen, and a lot of other guys, Dr. Adam Hotchkiss. It was a great weekend to spend some good time with the guys over at Merrick Health. And now I'm a webinar presenter for Merrick Health. So mission accomplished. Let's move over to the next slide. Let's see. So a lot of people ask me about hormone replacement therapy, right? I mean, my entire YouTube channel is basically about harm reduction and risk mitigation surrounding performance-enhancing drugs. A lot of questions I get about testosterone replacement therapy. So I always advise people before you go in for testosterone replacement therapy, right? It's a hot topic nowadays. Everybody wants to be on the TRT bandwagon. But why don't we try to optimize health first? Because in many cases, TRT is not required. The low testosterone is a symptom of something underlying by being in a poor state of health. So ideally, you want to get in a good state of health first before you start TRT, because maybe TRT isn't even required. And so if you're you're not sleeping according to your circadian rhythm, not sleeping at least 7 hours per day, going to bed when the sun goes down and waking when the sun comes up, maybe this is one of the reasons why your testosterone levels are low and why you feel lack of energy. And especially if you have undiagnosed sleep apnea, these are all things that you can mitigate with a sleep study using a CPAP or an APAP machine. And ultimately, this could increase your overall quality of life and perhaps your testosterone levels as well with some other, dietary interventions and lifestyle changes. If you were to do TRT at one point, I would suggest everybody to be below 12% body fat for two main reasons. One of them being is that testosterone converts into estradiol in adipose tissue. So if you notice that your testosterone levels are disproportionately low, but your estradiol levels are disproportionately high and you have high body fat, let's say 20%, 25%, 35%, by bringing that body fat levels down, your potential for aromatization also goes down, and thus your testosterone levels might go up. And the problem also is with body fat is that it increases your blood pressure. Body fat is literally compressing your arteries and your veins, increasing blood pressure. Now, one of the side effects of increasing testosterone is increased blood pressure, which you can mitigate with, again, a magnesium and calcium intake, more on this later, or ancillaries, but I would still recommend everybody to first take into a direction where you start to optimize your overall health before you look into testosterone, because the outcome of TRT is going to be significantly better when you're in a good state of health. I would advise everybody to do a longitudinal blood work so you can kind of see how your health is improving before you start TRT. So you have a firm grasp of what's going on in your body regarding your lipid levels, regarding your complete blood count, regarding your liver function and your kidney function, and of course, your hormone levels. Once you start going through the process of doing blood work every couple of months, you get used to it, but you also know what to expect and how to interpret those results under guidance of a medical professional on what is going to change when you do start TRT. Because in the end, testosterone replacement therapy will skew your lipid parameters and perhaps, bring your SHBG down, increase your estradiol, which again, you'll all have to mitigate with particular practices. I would advise everybody to focus on a healthy diet, maybe follow an elimination diet, minimize processed foods, because a lot of people, they have intestinal problems. They don't feel as good as they should be feeling. Again, if you eat a lot of processed foods, high caloric foods, your body fat levels might be high, which isn't an ideal state of health. So optimizing your diet is really a game changer for a lot of people and might ultimately pull the needle from feeling androgen deficient and feeling sufficient again. Health supplementation goes a very long way. Something as simple as a general over-the-counter multivitamin or other health supplements that can improve your overall state of health, but we'll address a little bit more later on. I would minimize outside stressors because cortisol has a very suppressive effect on your endogenous testosterone production. So if you're chronically stressed from school, there's still guys out there that are androgen deficient when they're teenagers, which is very unfortunate, but it's happening more and more nowadays. If you're stressed from work, stressed from your partner, other stressors, of course, it's easier said than done. But if you really try to address these outside stressors and bring your stress levels down, then you no longer have this suppressive effect of cortisol on your testosterone production, and testosterone levels should go up to a certain extent. Ideally, you're financially secure for testosterone replacement therapy because guidance is not cheap and the blood work is not cheap, and you'll have to do that continuously until you dial in your TRT protocol. And your TRT protocol might not be testosterone replacement therapy. It might be hormone replacement therapy consisting of testosterone, DHEA, Pregnenolone if needed, human chorionic gonadotropin, and some ancillaries to keep you healthy. So TRT is never just TRT. It's usually a couple other things on top. And because you have to do blood work and get proper guidance, personalized advice on your blood work results and how to proceed for the next couple of months, you need to be financially secure to make sure that you can ride this out to the end. Mental maturity comes a long way when it comes to TRT because you have to inject, you have to be rigid, you have to be diligent with the administrations. And I think if you're a little bit all over the place, one of the reasons why your testosterone might be low, then TRT is not for you, because if you start missing shots and then doubling up on the shots, you go into this hormonal roller coaster, which I've seen unfortunately many times happen with beginners of testosterone replacement therapy. They're not as diligent as they should be. And thus, the outcome of their TRT is not that great. Fully understand of the possible side effects. This is something you can always discuss with the healthcare providers over at Merrick Health, right? If they're going to guide you for testosterone replacement therapy. And otherwise, you can consult many videos on my YouTube channel where I teach you exactly that and what to look out for regarding blood pressure, regarding hair loss, regarding libido changes, mood changes, right? All these things you need to have a firm grasp on so you're well prepared. And again, for TRT, it's better to be over prepared than end up with a boatload of side effects that you did not expect. I would advise everybody at least to do a semen analysis and perhaps a testicular ultrasound following the semen analysis. I believe one of the partners of Merrick Health offers a semen analysis where you can actually freeze your semen samples. The name eludes me now, but we'll link it down below. So after you do a semen analysis, let's say your testosterone levels are down, right? But your semen parameters are good. You want to bring your testosterone levels up, which unfortunately, in many cases, brings your semen parameters down. So if this is your starting point, low testosterone, high fertility, freeze it. Freeze it for a later point in time. At least you know that your fertility parameters can also recover following testosterone replacement therapy if you decide to come off and get your partner pregnant. This is the position that I'm in now. I took performance enhancing drugs for 14, 15 years. And now that I'm on HCG monotherapy, my fertility parameters over the course of a couple of months turned out to be very, very, very good. But because I started at a time, day and age where we did not have access to this information, educators like myself, I did not do a semen analysis. So I regret this. I did a semen analysis in the middle of doing steroids. Now, if you notice that your testosterone levels are low and your semen parameters are low, right, or maybe zero, then I would highly advise you to do a testicular ultrasound to look for a varicocele or issues with your testicles or a hydrocele. Some of these things can really have a negative effect on your total testosterone and fertility parameters. And if it's a structural issue, then it doesn't matter what you do. The blood flow to the testicles is not optimized. And how are you going to produce adequate testosterone and adequate semen if the blood flow and the nutrients are not sufficient? So you could do everything right. You could be in a good state of health. You can go to the gym. You can eat healthy. You can sleep according to your circadian rhythm. Take all the over-the-counter health supplements that are known to boost testosterone levels. And if you have a horrible varicocele, nothing much is going to come out of it. Your total testosterone levels are still going to be low and your fertility parameters are still going to be low as well. So you might need to undergo surgery. Again, that's something you need to discuss with the person who oversees testicular ultrasounds and interprets those results. I'm not entirely sure what the doctorate is called. But there are professionals out there who can do surgery and fix varicocele or other structural issues, allowing you to maybe not need TRT, allowing you to have normal endogenous testosterone production and normal endogenous fertility parameters, which are suitable to get somebody pregnant. So again, all these things are pretty important to do before TRT. And what I would recommend also everybody to do is organ imaging and a genetic analysis, but that isn't always required. I would look into your family history, see if there's anybody with, severe sickness like cancer or other problems with their organs. You might want to be ahead of the curve and preventatively analyze your organs and do genetic testing so you have the data so you can make better decisions going forward. Moving over to testicular function, right? On the subject of testicular function. Let's say you did your testicular ultrasound, you don't have a varicocele, your testicles function properly. There's something you can look into. That's human chorionic gonadotropin, HCG, monotherapy. You can do that with subcutaneous injections, albeit that the clinical literature usually goes with intramuscular injections. From my personal experience, I never really noticed a difference between intramuscular and subcutaneous administrations. And since intramuscular administrations over time, we're talking about decades here, even with insulin syringes, will build up scar tissue. I have a lot of experience with scar tissue doing bodybuilder cycles, so I would not recommend it. Nowadays, if I had a time machine, I would do everything sub-Q. So that goes for human chorionic gonadotropin, but also hormone replacement therapy. I would administer, based on the clinical literature, between 250 IUs to 500 IUs subcutaneous daily, every other day, or tri-weekly. And it really depends on what you want to accomplish, because I have let me overlay one study here. Let me see if I can show that. So here, you see in this study, post-treatment with intratesticular, post-treatment of HCG monotherapy, intratesticular testosterone was 25% less from baseline in the 125 IUs HCG group, 7% less than baseline in the 250 IUs HCG group, and 26% greater than baseline in the 500 IU HCG group. The results demonstrate that relatively low dose of HCG maintains intratesticular testosterone within the normal range in healthy men with gonadotropin suppression. Now, this is in the context of not taking hormone replacement therapy. Oh, there's my slide here. So if you go to do, HCG monotherapy, then you already see that from a dose of 250 IUs, you get sufficient levels, which is comparable to baseline. And then as you ramp up the dose, 500 IUs should give you 26% more. And when you look at fertility studies that go up to 1500 IUs, testosterone levels are significantly higher compared to baseline. Now, you'll have to decide, based on what you discuss with your primary healthcare physician over at Merrick Health, if that's going to be daily, every other day, or 3 times weekly. Personally, what I'm doing right now is 1,000 IUs HCG 3 times per week, Monday, Wednesday, Friday. My testosterone right now is 850 nanograms per deciliter. And without this HCG monotherapy in place, I think my testosterone levels would be around 600 nanograms per deciliter based on previous results when I came off steroids completely. So this is a significant difference. This is an increase of 35%. Just keep in mind that I'm 40 years old and I have some steroid cycles under my belt. So some people might get significantly higher testosterone on 500 IUs HCG 3 times per week as monotherapy, right? These are all considerations for you to, try and discuss with your primary healthcare physician before you start testosterone replacement therapy. There's also what is very popular nowadays is enclomiphene monotherapy. This is taken orally, so you don't have to do any injections. That's daily, every other day, or 3 times weekly, and the dosages range between 6.25 milligrams to 25 milligrams. What difference between HCG and enclomiphene is that HCG simply stimulates testicles, replaces the luteinizing hormone signal that your pituitary would send to the testicles. LH and HCG work on the same receptors. As a result of that, LH and FSH levels probably come down. So you still have pituitary downregulation. You're shut down, but the testicles are still active because you're stimulating the production of testosterone and fertility, spermatogenesis downstream with this medication. Whereas with enclomiphene, you're blocking the estrogen receptors on the pituitary and the hypothalamus, and thus luteinizing hormone and follicle stimulating hormone levels go up, which stimulates testicles into testosterone production and spermatogenesis. And this sounds very, very appealing on paper, but the problem is that selective estrogen receptor modulators have various negative side effects. One of them, the most worrying in my opinion, is the potential for clotting risk. Now, when you start doing research, you see that Clomid has clotting risk. You see that tamoxifen, Olvidex, has clotting risk, raloxifene, tormifene, but not enclomiphene. And since enclomiphene is a reasonably new selective estrogen receptor modulator, it is part of clomiphene. Clomiphene is about 2/3 enclomiphene and 1/3 zuclomiphene. They're stereoisomers. So the molecular structure is exactly the same, but they're folded different. And enclomiphene is the one that increases luteinizing hormone and follicle stimulating hormone. And overall, the most positive effects are coming from the enclomiphene regarding the functioning of the pituitary and the hypothalamus. And it's zuclomiphene that allegedly gives the most side effects. The problem is it hasn't really been investigated that much separately. So enclomiphene has about 100 studies or up to 100 studies that you can do research on. In the clinical literature, you see a lot of case reports, and it's well established that clomiphene has clotting risk, but none of this has been disproven with enclomiphene. So I would always proceed with caution. Maybe look into your clotting factors, maybe do a CAC score, right, to see if you have a coronary artery plaque buildup, because nowadays you can't be too careful about clots, unfortunately, right? That's not through anybody's doing. That's just the world that we live in nowadays. So now that you know, please discuss this with your healthcare provider. Even though the administration is significantly easier, a lower barrier of entry, I feel that based on all the research that I've done, that the risk is a little bit higher compared to HCG monotherapy. And well, otherwise I would run enclomiphene right now and not HCG. So keep this in mind. Next one, when you're ready, right? You tried HCG monotherapy or enclomiphene, your testosterone levels came up slightly, but you're still not happy, and you want a little bit, try something new, right? You want to see what's behind door number 2. Then testosterone replacement therapy is probably an option. Testosterone replacement therapy is, again, like I mentioned before, not just testosterone, it's hormone replacement therapy. That's testosterone, human chorionic gonadotropin, dihydroepiandrosterone, and pregnenolone. And DHEA and pregnenolone are both neurosteroids that aren't always required. And this is why very important to do your blood work, because, of course, DHEA and pregnenolone levels also decline with age. But you see in a lot of younger individuals that do everything right. They're healthy, they go to the gym, they sleep properly, they're low stress, already graduated, or they're in a good relationship. You see that their testosterone levels might still be low, but their DHEA and pregnenolone levels might be sufficient. And when they try HCG monotherapy or enclomiphene monotherapy or testosterone replacement therapy, in that case, testosterone levels come up, obviously, to, let's say, the 2/3, 3/4, or top of the reference range, or slightly over that. The DHEA and pregnenolone doesn't move. Their adrenal glands still produce sufficient amounts of DHEA and pregnenolone, and they don't need to go the supplementation route. But as you get older, just like testosterone levels decline, DHEA and pregnenolone levels decline also. So maybe by the time you're 30, you notice that DHEA and pregnenolone supplementation is required. Maybe it's only DHEA, maybe it's only pregnenolone. This we assess with blood work parameters, and again, something you have to discuss with your healthcare provider over at Merck Health to see which of these options is the most how do you say this, the most relevant to you as an individual. So once you got that under control through multiple blood work analyses, then you might have to put lipid management in place, or blood pressure management, or estrogen management, but we'll get into that a little bit later on. So let's discuss testosterone first. You can do subcutaneous administrations, like I mentioned earlier, or intramuscular administrations. The main difference between both routes is that from all the blood work that I've seen in myself and all of the clients that I've worked with, is that subcutaneous administrations will give you lower total testosterone levels, so lower serum levels, but also results in less aromatization into estradiol, whether that's daily, every other day, 3 times weekly, biweekly, or even weekly. In the subcutaneous depot, the injection site, the blood circulation is less, and the lipases which work on the injection depot break that down, allowing the testosterone annotator cypionate to go systemic. That process is slower compared to intramuscular because intramuscular has more vasculature, more blood flow, and perhaps more lipase activity. So this is the main difference, right? And again, besides the scar tissue buildup over decades, I would still prefer daily microadministrations subcutaneously. Serum levels will be the most stable, no terrible fluctuations. Estrogen levels will be the most stable, no terrible fluctuations, no acne. Dihydrotestosterone levels ultimately are going to be the most stable, so potentially less hair loss if you're prone to it. And otherwise, look into minoxidil, ketoconazole shampoos at low and effective dosages, not too much to the point to go systemic, because then you can also feel a little bit off. So if you go with daily microadministrations, even though it's more cumbersome, even though you have to do it every single day, if you incorporate that, let's say after your shower, it becomes as easy as brushing your teeth. So in the beginning, it might be a roadblock, a little bit higher barrier of entry, but once you get used to it, you shower, you brush your teeth, you do your injection, and you go about your business. Another benefit of doing daily subcutaneous microadministrations is that the influx of testosterone is not great every single day, because a lot of people notice, even with HCG monotherapy at higher dosages, that they get insomnia. With enclomiphene, this is also a known side effect. So let's say that you go from a 300 nanograms per deciliter testosterone to 600. That's double. If you go from 300 to 900 to 1200, that's 4 times higher. And some people experience insomnia in this increase that happens over a couple of weeks. So again, you might want to start low and build your way up, depending on the hormone replacement therapy protocol that you're after. Because if you get insomnia, then you might have to reduce the dose until you get used to this elevated testosterone level. So from my personal experience and people that I've talked to, switching to daily subcutaneous microadministrations seems to bypass and prevent this in most cases. But again, if you go to a high dose, then you might still get insomnia. Again, discuss this with your primary healthcare physician. General dosages of testosterone replacement therapy are between 100 milligrams to 200 milligrams weekly. But if you notice that your serum levels, even on 200 milligrams weekly, are not sufficient because you're a high metabolizer, then obviously the dosages need to be increased, right? And then manipulated based on your blood work results. Besides the testosterone, I would still consider human chorionic gonadotropin to be hormone replacement therapy, even though men produce trace amounts of HCG, right? We're not pregnant women. Pregnant women can detect HCG in their urine, but men generally have undetectable HCG levels. But it's still, it's probably the best option you have because recombinant luteinizing hormone, it seems to be very difficult to source. So human chorionic gonadotropin is just purely there to sustain testicular function. You can choose between subcutaneous or intramuscular administrations for the same reasons as testosterone. The protocols is usually every other day or tri-weekly, so that's a little bit different than HCG monotherapy, because again, based on the clinical literature, which I just showed you guys, at 250 IUs to 500 IUs every other day or 3 times weekly, intratesticular testosterone production is sustained or slightly supraphysiological. So if you go with a combination of 100 milligrams testosterone plus 500 IUs HCG 3 times per week, your testosterone levels are significantly higher than without the HCG using testosterone solo, because your testicles are still active and they're producing testosterone and estrogen and dihydrotestosterone on top of the exogenous testosterone that you're taking. Right? All of the citations will be down below when you watch this on my YouTube channel, which I will publish this video as well. Let's move over to the administration frequency for DHEA and Pregnenolone. Again, if your blood work parameters show that you need DHEA and Pregnenolone, then you could either do that orally, sublingually, or by topical cream. Personally, I don't have so much experience with topical cream, so if you're interested in doing that to sustain DHEA and DHEA sulfate levels the most, it seems to be very stable for some individuals, then please discuss that with your primary healthcare physician over at Merck Health. I've always done it orally, but as of late, I switched to sublingual administrations after I had a good discussion with Dave Lee and watched some of his videos on the subject. Dave Lee, for the guys that watched a previous Merck Health seminar with Dave Lee, he's very knowledgeable on DHEA and Pregnenolone. And I remember him saying that sublingual might be the best route to go with, because then it gets stored as DHEA sulfate, which acts as a reservoir for DHEA. You have free DHEA and DHEA sulfate. And DHEA sulfate is just there temporarily, similar to testosterone enanthate or cypionate. It has a sulfate attachment, and thus it's biologically inactive. It can readily convert into DHEA sulfate back into DHEA and become biologically active, and later on convert into testosterone. So if you're going on DHEA, then your testosterone levels might also be higher than without it. So a combination of testosterone, HCG, and DHEA, all at low and effective dosages, will yield a significantly higher serum testosterone level compared to just going with one of these options. So I do sublingually morning and evening. Personally, I take 12.5 milligrams morning and evening, because on HCG monotherapy, even though it's 1,000 IUs 3 times per week, which is a pretty high dose, a fertility dose, my testosterone levels are great, but my DHEA levels are still insufficient. They're at the bottom of the reference range. So my adrenal gland didn't really respond to HCG monotherapy at this time, so I supplement on top. And if you're taking a lower dose of HCG, but your adrenal glands are still responsive, then you probably don't need DHEA. Again, your serum levels will tell you exactly how you need to proceed. And if they're really, really low, then in some individuals, you need 50 milligrams daily, or maybe even higher, right? In the elderly, you see, based on the clinical studies, they go up to 100 milligrams DHEA daily. And with Pregnenolone, it's pretty much the same. You can take it orally or sublingually, ideally daily, in the morning or in the evening, or split morning and evening. And the dosages are also very similar to DHEA, between 10 to 50 milligrams daily, albeit then in a lot of cases, what I've seen, Pregnenolone might not be required. At this point in time, I don't take Pregnenolone myself. I take it when I take hormone replacement therapy, but not currently. From what I've noticed with myself and many of the people that I work with, if they need Pregnenolone, it's usually half the dose of their DHEA dose. But again, discuss this with your primary healthcare physician, because they're the one who interprets your blood work results and ultimately the one who are going to guide you. Moving over to blood work parameter management. Lipid management. There are many over-the-counter supplements which help with lipids, besides healthy eating and doing daily fasted cardio or 10-minute walks in between meals, and just staying active. Generally speaking, right, following a healthy lifestyle usually improves lipid parameters quite substantially. Beyond that, there's citrus bergamot or berberine or high-potency fish oil, even niacin, even though I'm not a really big fan, because the effective form of niacin is the flush version. That's the one that brings your total cholesterol levels down, but that's also very unpleasant. I don't like beta-alanine and I don't like niacin, but there is some scientific evidence that shows that niacin can be very beneficial to lower total testosterone levels. Then there's ezetimibe. It's probably the best medication out there that can reduce low-density lipoprotein and total cholesterol levels. Ezetimibe works by blocking the absorption of dietary cholesterol and promotes the excretion of cholesterol within the liver. So, to keep it simple, long story short, testosterone instructs cells of the body to produce more cholesterol. Now, you can reduce a little bit of this cholesterol production by removing simple sugars, which have a similar effect, telling the body to produce more cholesterol. A primary production site of cholesterol is within the liver. So if you inhibit the absorption of cholesterol in the liver, then it doesn't go systemic, obviously. You can't detect it in total testosterone or LDL lipoproteins within the bloodstream. And if you promote the excretion, then you can literally get rid of this additional cholesterol that your liver synthesizes and is coming from the other tissues in the form of HDL. LDL transports cholesterol and triglycerides away from the liver in an attempt to bring that to other tissues. But if you're on testosterone and your other tissues are also producing cholesterol, then they might not accept this LDL. They want to get rid of this cholesterol through HDL, which transports cholesterol and triglycerides back to the liver. But if your liver is also full with the cholesterol, then it increases hepatic lipase, which breaks down HDL, and now you have more transport away and less transport to the liver. So ezetimibe can kind of offset this increase in cholesterol, and it's even been shown to, reverse various metabolic conditions in people who are otherwise unhealthy. There is some scientific evidence about ezetimibe that it lowers omega-3 fish oil absorption. But from all the blood work that I've seen of people who are able to check their serum omega-3s before and after ezetimibe treatment, it doesn't appear to me that much of a substantial difference. And again, you can always take your ezetimibe in the morning and then supplement with fish oil multiple times per day later in the day when the ezetimibe is already gone systemic. So this is things you have to consider. But personally, from all the blood work that I've seen, I wouldn't worry about it too much. The benefits of ezetimibe far outweigh the potential negative side effects. There's registrized, which is a natural lovostatin. It used to be very popular in the bodybuilding space, but many of us have made the switch to ezetimibe because unfortunately statins might cause myalgia, muscle soreness, or other problems. So it seems that the one that is the most favored and the most popular nowadays is rosuvastatin. Again, I would only use this if ezetimibe and the other health practices are insufficient to bring your lipids within normal parameters when you're running testosterone replacement therapy or before that point. And there's other statins and even PCSK9 inhibitors, which might be end-state lipid management. And I feel that in many cases, it's not required. But again, if it's required medically, then please discuss this with your primary healthcare provider. Blood pressure management. Again, balanced electrolyte intake. Magnesium helps the arteries to relax because the arteries are smooth muscle also. So you have skeletal muscle, obviously, that responds very well to calcium, magnesium. Calcium helps to contract your muscles, and magnesium helps to relax. Now, if you follow the lifestyle, you go to the gym and you eat healthy, and you also take some testosterone replacement therapy, then in many cases, your magnesium intake and requirement needs to go up. And if you overlook that, or we're already magnesium deficient, it's actually one of the very common occurring deficiencies in the world. Vitamin D3 and magnesium deficiencies are very, very common. So if you start supplementing with magnesium and perhaps eat calcium-rich foods, I wouldn't supplement with calcium because it's too much calcium in your bloodstream in one go. But if you supplement with calcium-rich foods and take vitamin D3 and vitamin K to help bring that magnesium and calcium to the right places, over time, as your calcium and magnesium stores build up, you'll see that blood pressure management, it probably becomes an afterthought. And otherwise, right, there's over-the-counter supplements or ancillaries who can help with that. So I would look into calcium and magnesium first, right? There's magnesium citrate and bisglycinate and threonate, which can help with sleep quality. I would look there first because magnesium deficiency is so common that I would look there before applying any kinds of herbs or ancillary to keep your blood pressure under control. And again, if your body fat levels are high or you have chronic sleep apnea, address that also because magnesium might not be sufficient. There's Carditone, a herbal formula, albeit that it's not clinically recognized. I've seen it reduce blood pressure in bodybuilders quite dramatically. There's Tadalafil, Cialis. Of course, it was initially investigated as a blood pressure medication and then discontinued because of its long half-life. I believe it has a half-life of about 32, 36 hours, so it builds up over time. But the side effect of Cialis tadalafil is, high-quality erections. So I would take it for that and then enjoy the blood pressure management as a warm welcome side effect. Now, if you're going with Cialis, then it's very likely you don't need Telmisartan. But if you feel that blood pressure management of Cialis is not sufficient, again, as a side effect, you enjoy the the libido, the erection quality increasing properties, you enjoy that, but you need more blood pressure management, then I would remove the tadalafil, the Cialis, and make a switch for Telmisartan. Again, make sure you have an Omron blood pressure cuff, whether that's around the wrist or the arms, because Telmisartan can drop blood pressure quite dramatically. I would start low after tracking your blood pressure for multiple days in duration. That's when you wake up, before you go to the gym, after you go to the gym, in the afternoon, which is generally when blood pressure levels are the highest, and then before bed. So you keep a blood pressure log, keep track of when it's high, when it's low, and maybe manipulate your diet slightly, increase your magnesium intake if needed. And then when you have firm grasp of how your blood pressure fluctuates, consider Telmisartan. Right? And it's, again, something you have to discuss with your healthcare provider. You could start low and build your way up depending on how your blood pressure is under control. And if you don't respond well to Telmisartan, or you get adverse effects, which again, there are side effects associated with Telmisartan, then look into other ACE inhibitors or ACE blockers to, get blood pressure management, but not have the side effects that you're getting from Telmisartan. There's many ACE inhibitors, many ARB blockers, so please discuss it with your doctor, because they probably know what is best for you. Then regarding estrogen management, besides the daily subcutaneous microadministrations and having low body fat, you can look into diindolylmethane and calcium D-glucarate. These are over-the-counter supplements that help with estrogen balance and estrogen excretion, metabolism. Diindolylmethane is found in cruciferous vegetables, which helps with the balance between estrone and estradiol. When you take exogenous testosterone, it only converts into estradiol. When you take HCG, it mostly produces testosterone and then estradiol, but estrone to a certain extent. But you see, if you do your blood work, you check your total estrogens, your estrone, and your estradiol, that your estradiol is disproportionately high to your estrone. And so your estradiol comprises more of the total estrogens that you have. So this balance you can offset, bring that closer together with diindolylmethane. Again, it's found in cruciferous vegetables. You would have to eat a boatload of broccoli and kale to the point you would have severe gastrointestinal upset. So go the supplemental route. When you start doing research, you will find that diindolylmethane actually inhibits the androgen receptor, which is obviously not what we're after. It might downregulate the androgen receptor, but this is only studied in the context of prostate cancer, not in the context of skeletal muscle or androgen receptors in other tissues of the body where you would want to have positive effects. So I would say from all the research that I've done and the people that I've talked to using diindolylmethane on hormone replacement therapy or full-blown steroid cycles is that there's no adverse effect. Nobody notices that their anabolism or libido or overall productivity in the gym or quality of life goes down by adding in diindolylmethane. And if you know that androgen receptors have a lot of genetic polymorphisms and variations between tissues, then you could understand that diindolylmethane actually might be a good thing to take in case you have prostate cancer in your family, because it seems to only work on the prostate gland, right, in cases of prostate cancer. And with calcium D-glucarate, it does increase metabolism of steroidal hormones or neurosteroids. A lot of compounds in the body are glucuronidated. Some of this is recycled within the intestinal tract or within the body through glucuronidase enzyme activity, where it attaches glucuronidase and then metabolizes it off. And now this compound that you wanted to excrete through the kidneys is biologically active again. So by taking calcium D-glucarate, all the compounds that your body wants to excrete are glucuronidated and stay glucuronidated, marking them for excretion, because there's enough glucuronidase available for your body to excrete these compounds. And when we're talking about compounds, we're talking about estrogens, testosterone, many other toxins, and also some of the medications that you're taking. So again, discuss it with your primary healthcare provider. There's something to say for diindolylmethane and calcium D-glucarate, but it also depends on what kind of other medications you're taking, which we're not discussing in this presentation. Otherwise, right, if the daily subcutaneous microadministrations are not working or reducing your body fat, or diindolylmethane or calcium D-glucarate is not a route you want to go with, then exemestane or anastrozole are medical aromatase inhibitors that will inhibit the conversion of testosterone into estradiol. The downside of this is that exemestane and anastrozole reduce the conversion, right? The serum estradiol is now in range, but total testosterone might be higher. And in this difference in increased total testosterone, you might aromatize or 5-alpha reductase more into dihydrotestosterone. So estradiol goes down, but DHT might go up, and thus you increase the potential for hair loss. And it's the same way the other way around. If you notice that you get increased conversion of testosterone into dihydrotestosterone, I don't have a slide for this, but it just springs to mind. Your DHT levels are high, and you take a 5-alpha reductase inhibitor to bring that down. Now your estrogen goes high. So this is why it's so important to do blood work and assess what side effects you're suffering from, because, from a cosmetic appearance, men usually experience 3 side effects. It's either hair loss, it's either gynecomastia, or acne. And maybe you get 2, right? Hair loss and gynecomastia, or hair loss and acne, or gynecomastia and acne. 2, if you get 3, then yeah, it's very unfortunate. I get acne, but no hair loss, and gynecomastia, which I would have to remove with surgery. So you have to be well ahead, do the blood work frequently, because if you let it run, right, you're taking an aromatase inhibitor and now your DHT levels are high. And then one day you wake up looking in the mirror and you're like, I almost look like Steve now. What the hell is going on? This is not what I wanted. Right? I prefer to be bald. I don't like hair, but some people really enjoy their hair. So this is something you need to be aware of. Aromatase inhibitors increase the potential for hair loss, and 5-alpha reductase inhibitors increase the potential for gynecomastia. Do your blood work, adjust frequency until you dial in your TRT. Body fat management, again, to keep your estrogen levels down. Elimination diet. You can follow a paleo diet, a pescatarian diet, a ketogenic diet, a vegan diet, a carnivore diet, a low FODMAP diet, whatever diet works for you. Well, how do you say this? There's a lot of fanatics in the diet space. I don't really mind what diet you follow. If it's carnivore and it works and you keep your total cholesterol levels under control, go for it. If you like paleo, go for it. If you like pescatarian, go for it. Personally, I do keto. It gives me the most cognition out of all of the diets that I've tried. And I'm not 100% keto. I still have fruit post-workout 4 to 5 times per week. So I don't really exclude any food sources, right? I have my carbs, I have my fats and my protein sources and my vegetables. And I feel that it's doing me a world of good. My digestion, absolutely perfect. But it takes a couple iterations of dietary adjustments before everything is dialed in. What I can tell you is minimizing processed foods, which is hard in America, right? I'm going to be honest, I was in America for an entire month last year, and it's very hard to minimize processed foods unless you have your own kitchen, right? I was traveling, so I ate, well, no, let's not go there. After eating out a lot, my blood work parameters were not good. Yeah, so I would advise people not to do that every single day if you live in the US, or at least not go to the places that I went to. Maybe I just made poor choices. Anyway, so minimize processed foods, right? Cook your own meals, or go with a meal prep company that is known to produce high quality food that is fresh and that you can microwave and still taste good with a lot of protein, healthy carbs, and healthy fats. Make sure that you're always in a micronutrient sufficient state. This is very, very, very important. Not just magnesium, not just calcium, vitamin D3, and vitamin K, all of the micronutrients. Your body just doesn't work on calories alone. It doesn't work on testosterone alone. It works on micronutrients. B vitamins contribute to hundreds of processes. Magnesium contributes to hundreds of processes. And niacin, right, one of the B vitamins, converts into nicotinamide mononucleotide, which contributes to NAD+, which NAD+ and some of its derivatives regulate thousands of enzymatic reactions, including the conversion of testosterone into estradiol, including the conversion of testosterone into dihydrotestosterone, and neurotransmitters. I mean, the list goes on. So you need nutrients to function correctly, and you'll be surprised how many ailments you can solve simply by eating healthy. And then, of course, caloric adjustments and restriction based on your individual goals. Exercise. Vigorous resisting training is known to increase testosterone levels, improve androgen receptor density, and even reduce myostatin levels. So with all of those benefits, why not go to the gym? 10-minute walks following meals to improve insulin sensitivity has been shown to be as beneficial, apparently, compared to metformin. Cardio, whether that's fasted or post-workout, the scientific evidence is always based on hundreds of studies. It doesn't really matter when you do fasted cardio or post-workout cardio. Just do cardio and the fat loss will be the same. But that's usually not performed in a context of hormone replacement therapy and using fat-burning aids like L-carnitine or even Cialis, which has some scientific evidence behind it that it can increase lipolysis. And then there's always a standing desk or treadmill to kind of keep you active. Stephen was just doing this right now before we started this presentation. Not Steve, Stephen, one of the good guys over at Merrick Health. All right. There's also pharmacological aids for body fat management. So carnitine, whether that's oral or injectable, that is highly beneficial to help with the absorption of medium and long-chain triglycerides into the mitochondria, where they're burned for energy production, so you can lose some body fat. So if you combine, I know Cialis is a little bit down the list, but let's just go over this combination. If you combine tadalafil, which increases lipolysis, with carnitine, which increases fatty acid absorption and oxidation, then you basically have a one-way street from your adipose tissue to the mitochondria. And assuming you do, cardio activity and keep your calories low for favorable fat loss, then this over time results in fat loss and maybe reduce the requirement for an aromatase inhibitor to keep your testosterone levels nicely in range while keeping your estrogen in range. If that's not sufficient, if the carnitine and the tadalafil is and the caloric restriction is making you significantly hungry, then consider looking into glucagon-like peptide 1 receptor agonists, like liraglutide, dulaglutide, or semaglutide, which is a combination glucagon-like peptide 1 receptor agonist with gastric inhibitory polypeptide, also known as glucose-dependent insulinotropic polypeptide. Two names, one function. Tirzepatide specifically has been FDA approved as of recent, so availability might vary. There's another compound called retatrutide, but that's not FDA approved yet, so let's leave that off the table. I found that liraglutide is very beneficial if you still want to have a normal appetite on Saturday or Sunday, because dulaglutide, semaglutide, and tirzepatide have very long active lives. Now, this is something you need to discuss with your healthcare provider. What I've always done is daily or 3 times weekly administrations. Liraglutide, I would take a low dose daily, and dulaglutide, semaglutide, or tirzepatide, instead of 1 administration per week, I would do 3 administrations at a lower dose. And what I've noticed, again, no scientific evidence to back this up, but this is just pure anecdotal experience. What I've noticed is that the weekly dose can be significantly lower if you inject 3 times per week. Right? Your mileage might vary, everybody is different, but instead of running 5 milligrams tirzepatide per week, which is the starting dose clinically, or 2 to 5 milligrams semaglutide, I can get away with 1 milligram or half a milligram 3 times per week for sufficient appetite suppression. Now, glucagon-like peptide 1 receptor agonists are a hot topic nowadays, right? There's a lot of, it's in the news, it's on billboards in the United States. I think me and Derek from More Plates, More Dates, the owner of Merrick Health, the co-owner, we were one of the first to talk about these compounds publicly. It's now gone mainstream. All your favorite celebrities are running these kinds of compounds, but it also means that there's a good amount of scientific evidence that we can review. So let me briefly go over this study, because glucagon-like peptide 1 receptor agonists used long-term have been associated with the risk of thyroid cancers by 58%. Again, this is a scientific study you would be well off reading yourself, because there's a lot to go into. And it's been associated with medullary thyroid cancer by 78%. Patients included in the other 2 groups of exposure of less than 3 years and over 3 years also showed a higher risk of incidence of thyroid malignancy, although the intergroup difference was not significantly relevant due to a low number of cases. So that's only 40 cases. So keep this in mind, right? All drugs that are shown to be highly effective in a certain extent also have negative side effects. So that is unfortunate. There we go. Let's get this out of the way. And this is also of note. Of 56,000 patients with type 2 diabetes, keep in mind that glucagon-like peptide 1 receptor agonists are traditionally type 2 diabetic medications, with a mean follow-up time ranging between 1.3 years to 5.4 years, a total of 180 cases with acute pancreatitis and 108 cases of pancreatic cancer were reported. So again, 56,000 patients and let's say 400 cases of pancreatic issues. I'm not entirely sure what that percentage is, but it's still statistically significant, and that's with long-term exposure. So I would like everybody to be well aware of these risks because you need to take all risks serious. And then here, regarding the Cialis, this is a small study where where it was shown that after 2 to 6 hours after injection of Cialis, free-form fatty acids and glycerol in the bloodstream increased, and that basically increases lipolysis without affecting cyclic guanosine monophosphate and nitric oxide levels in the bloodstream. And you didn't get a significant inflammatory response. So if you take Cialis, let me go back to the presentation. If you combine Cialis with carnitine, then I would say it might be a suitable route to potentiate more fat loss when you're already in a caloric restrictive state, and do cardio pre or post workout or in the morning and 10-minute walks, just keeping your energy expenditure up. Telmisartan is a partial peroxisome peripheral activated gamma receptor agonist, and even though the scientific literature is promising when it comes to PPAR gamma agonists, especially telmisartan, that it can increase metabolic activity and might result in fat loss. In practical application, I would not say that that's the case, right? Sometimes the scientific evidence plays out in the real world and sometimes it doesn't. I've talked to bodybuilders that took up to 80 milligrams of telmisartan per day and did not notice any significant fat loss, even in a caloric deficit, after ramping up the dose to 80 milligrams per day. Still, the scientific evidence shows that PPAR gamma activation improves metabolic energy expenditure and might result in fat loss. So if you were to go with an angiotensin receptor blocker, based on the scientific literature, I would prefer telmisartan. But again, there might be some contraindications there. And then there's metformin, which improve glucose homeostasis. But now that glucagon-like peptide 1 receptor agonists are there, and we discussed diet at length, I don't think that metformin is going to be needed. Now, regarding longevity optimization, I think we're already limited over time, so we're just going to go over this briefly. Regarding lifestyle practices, high quality sleep, healthy diet, and vigorous exercise, all good for longevity. Minimize outside stressors to balance out your cortisol levels, minimize oxidative stress. And I want to highlight one more study. I know studies galore on this presentation. One more study here is that the use of anabolic androgenic steroids in combination with vigorous exercise actually increases oxidative stress. So this study showed that both the experimental groups showed an increase in oxidative markers, concentrations after resistance exercise compared to the all right, so let me translate this real quick. You have a group doing resistance exercise and a group doing exercise, resistance exercise in combination with anabolic steroids. And the group taking steroids with exercise showed increased oxidative stress markers. Again, citations will be down below. A very interesting read. I think everybody that takes anabolic androgenic steroids or performance-enhancing drugs in general and goes to the gym frequently should read this study, so they know that they're basically increasing their oxidative stress parameters and thus need to increase their antioxidant intake, which makes it a little bit cumbersome because there's also 2 scientific papers out there that show that the immediate administration of vitamin C or other antioxidants post-workout blunts the post-exercise stress response. So which route are we to go? Right? If we really want to go with the scientific literature, you take vitamin C, ubiquinol, vitamin E, all the other antioxidants away from the workout, just like we space the ice baths away from the workout. So let's say 4-hour window before and after the workout, no antioxidants and no ice baths, but then at least you get some antioxidants in to blunt this otherwise oxidative stress that you would get from training on steroids. And yes, testosterone replacement therapy is being on steroids also, but the dose is clinically recognized. And for longevity, I would minimize recreational drugs. And yes, that includes alcohol. Alcohol is a globally accepted, besides Muslim countries, globally accepted recreational drug. Smoking, party drugs, etc. Right? Don't take those. Otherwise, the oxidative stress simply goes up. Regarding longevity, I think hormone replacement therapy is a great way to increase your longevity, because you see that with men with androgen deficiency, the quality of life and the overall duration of life might be diminished because of cofactors that come along from impaired hormone levels. Nicotinamide adenine dinucleotide, NAD plus IV administrations, but you can also take nicotinamide mononucleotide or nicotinamide riboside orally. This is probably the first thing you can look into. Very good for energy levels, very good for sleep quality. The scientific literature is a little bit thin. And now that David Sinclair is trying to monopolize nicotinamide mononucleotide, yeah, I'm a little bit upset, but at least nicotinamide riboside is still available. And if you're able to get nicotinamide adenine dinucleotide IV administrations, then this is probably the best way to go. There's glycine and N-acetylcysteine, also known as GlyNAC. A lot of scientific evidence behind it that it increases glutathione levels the most. And otherwise, there's always injectable glutathione, let's say between 200 milligrams and 600 milligrams, once, 2 times, maybe 3 times weekly, depending on the oxidative stress that you subject yourself to. Methylene blue is a great oxidative stress aid and a cognitive enhancing aid. We consider this a nootropic that upregulates and improves mitochondrial functioning. Ubiquinol, well studied in the context of exercise, a very potent antioxidant that helps with cardiac function. There's rapamycin, but I would only do that on days that you're fasting. And again, discuss this with your healthcare provider if this is something for you. Arcarbose and canagliflozin all have been shown to improve lifespan and longevity, right, in various animal models. And metformin and resveratrol have now been debunked as longevity aids by Dr. Peter Attia in one of the podcasts that he did with Andrew Huberman. So those are off the menu for longevity aids as of now. Oh, we're already at the end. Let me know if there are any questions. Let's go back to the, let's see. Let's go back to the screen.
First and foremost, Steve, I can't thank you.
One second. Let me stop sharing my screen. Where do I stop? Here it is. All right, my apologies. How was it?
Great. Yeah, I can't thank you enough for sharing your wisdom and expertise with all of us. There's a ton of questions here to go through. So if any of your questions don't get answered, please reach out to your health coach and your Merrick Health provider. They'll be more than happy to meet with you and talk through all of this together. First question from an anonymous attendee. What other medications are synergistic with TRT? Dr. Hotchkiss recommended low-dose daily tadalafil, and it's been incredibly useful for me. Are there any other treatments you recommended?
Yeah, so tadalafil is always a popular combination with testosterone replacement therapy, not only for blood pressure management, but also to improve erection quality and enjoyment in the bedroom. And again, there's some scientific evidence that it improves lipolysis. So I think that's always one of the first things you can look into if your TRT is successful. And then the rest are kind of ancillaries. Proviron has been known to work for some individuals. I usually don't include it on these kinds of talks because exogenous testosterone usually suppresses HCG. So while HCG might be elevated in the beginning of starting testosterone replacement therapy or when you're still drug-free, as soon as you go on HRT, SHBG comes down, freeing up more testosterone, and libido usually improves. Now, if you notice that your SHBG is still unfavorable, let's say 40, 50, 60 nanomoles per liter, and you're already on TRT for a while and you do everything right, then maybe look into a low-dose proviron, starting at 6.25 milligrams once per day. I don't believe in starting off at 25 milligrams, because then you have 4 days, 5 days of bliss, where your SHBG is favorable and your free testosterone is high, and thus your libido is great. And then you overshoot, and now your SHBG is too low. Now you have too much free testosterone. Now you might get insomnia. Now you might get too much aromatization into estradiol, and now your libido is off again. So start low, do some blood work, and slowly build your way up. On TRT, from what I've seen, most men do well with 6.25 to 12.5 milligrams per viron daily, if they need it at all. Yeah.
Excellent. A lot of questions around HCG and enclomiphene. First, optimal length of time for HCG Enclo monotherapy and or dual therapy?
Um, Personally, I don't believe in dual therapy, even though I know it's been prescribed. So you have enclomiphene, obviously, right, which is increasing the luteinizing hormone and follicle stimulating hormone signal. But human chorionic gonadotropin replaces part of this luteinizing hormone, and it's far more effective in increasing intratesticular testosterone production than luteinizing hormone is, because you take it at supraphysiological amounts. So let's say you take enclomiphene and your LH goes from 2 to 6, middle of the reference range, and your testosterone levels go up. Why would you take HCG? Because you're replacing part of the LH, you might actually get it down. And now you're taking enclomiphene just to get a follicle stimulating hormone level, which you could also take in the form of recombinant FSH. Now, this is what I'm doing, right? I'm taking recombinant follicle stimulating hormone and recombinant human chorionic gonadotropin, because recombinant luteinizing hormone I can't find. So I have to go with the best options. And I know that if I go with enclomiphene, my luteinizing hormone and follicle stimulating hormone levels will come up to a certain extent. But in order to improve my fertility parameters and have high testosterone levels, I wanted to go super physiological on my LHCG receptor stimulation. That's the combination luteinizing hormone, chorionic gonadotropin receptor, and the follicle stimulating hormone receptor. So I go super physiological. I think that the combination doesn't make sense to me, but I know that there's many healthcare providers who prescribe it. And again, if you have a good response on a low dose enclomiphene and a low dose HCG, and this works the best for you, then I'm all for it. I would still do additional testing regarding clotting, because again, those studies have not been performed yet. And since Clomid is about 2/3 enclomiphene, there's 2/3 the chance that this clotting risk is coming from the enclomiphene, not just the zuclomiphene. But I'm waiting for the studies. I'm waiting for the studies. So the duration is based in, if you're healthy. I know people who do HCG monotherapy indefinitely. I've been on HCG monotherapy for a year now, and my testosterone levels are 820. So if I wasn't a meathead bodybuilder and I didn't want to be more muscular than I am now, then all other things, my libido is great, my energy levels are great, my muscularity is great. Here, proof. See, still pretty good. Not as great as it used to be, but it's still okay. So all things considering, if I didn't have my selfish aspirations to be bigger than this, then I would be totally fine on this dose of HCG monotherapy. And I think if fertility wasn't such a priority, I would be able to bring it down to 500 IUs and end up around 700, maybe 750 nanograms per deciliter, which is, great. It's not stellar, but it's great already compared to what I would have without it. And I would be able to run that indefinitely. I know guys that I discussed many years ago, like HCG monotherapy was not being discussed in the fitness community. I'm one of the first ones who talked about it publicly, even though some of the medical professionals did it. Now it's understood in our community. So I put people on HCG monotherapy 5 years ago before trying TRT, and they just continued. They never proceeded to TRT because they didn't need it. They got their wives pregnant 2 times over because their fertility parameters were great. And so it really depends on you and how you feel. Right? If you get a great result and your libido is great and your energy is great, just stay there. Just stay there. But it's probably more expensive because HCG is the price has gone up substantially. So I know that I'm spending more money on HCG monotherapy than I do on testosterone replacement therapy with a low dose HCG. That's cheaper. And that matters also.
Do you have time for a few more? I know we're coming up
Hmm.
kind of on our time.
Yeah, keep going, man. I got another 30 minutes. Don't worry.
Tanner Fry asked, is there any evidence that HCG desensitizes Leydig cells?
Yeah, so a couple of years ago, I made videos about HCG receptor desensitization, right? So there's a combination luteinizing hormone chorionic gonadotropin receptor, which uses a G-coupled protein, which sends a signal into spermatogenesis when it's activated by luteinizing hormone or human chorionic gonadotropin. At that time, I said desensitization was a thing in the context of taking anabolic androgenic steroids, mostly nandrolone, trenbolone, tresbolone. These are the drugs that bodybuilders take. These are not drugs that are being prescribed. Maybe nandrolone is being prescribed, but trenbolone and tresbolone, especially at the dosages bodybuilders use. since the testicles also have androgen receptors and estrogen receptors and progesterone receptors, there appears to be a feedback when you take steroids at higher dosages and nandrolone or trenbolone and trestolone at higher dosages as well. So it seems that the signaling doesn't really work. Is there clear scientific evidence to support that? No, unfortunately not. Unfortunately not. So we can go with anecdotal bro science. From all my years in coaching bodybuilders on cycles consisting of testosterone and a 19-or testosterone derivative that could activate the progesterone receptor, you add in HCG because the testicular shrinkage is substantial to the point it's uncomfortable, where the testicles go in the body, right, in a colder climate, and it's very uncomfortable. In an attempt to bring testicular volume up, you add in the HCG. Initially, you get a response, and then they shrink smaller than before. And I've seen this happen over and over again. This is why I made that video a couple of years ago. But in the context of not running nandrolone, trenbolone, or trestolone, and keeping your testosterone dosages moderate, sane, right, for hormone replacement therapy purposes, not bodybuilder dosages, then I don't think that that's occurring. And you can take me as an example. I'm taking 1,000 IUs HCG 3 times per week without exogenous testosterone. And I even took this on TRT because I wanted my fertility parameters to come back. My fertility and testosterone levels have only been increasing since I started this protocol. Of course, that's me, right? But again, if you go through the citations, which I can provide, you see that long-term HCG usage does not shut you down if done with co-administration of testosterone at clinically accepted dosages. Yeah, and fertility protocols are maybe even higher HCG dosages for years on end. Yeah.
There's one in here that I know will be a good one considering the presentation you did at Swiss on carrier oils and inflammations. From Clayton, he's asking, what are the blood markers that measure oxidative stress?
Oxidative stress. So these are not commonly tested for. And I'm not sure if Merck Health has some of the markers that are related to glutathione. Because here in Thailand and many of the countries, they don't directly test for oxidative stress. You can check for inflammation, that's C-reactive protein, your lymphocyte to neutrophil ratio, your homocysteine levels, your ferritin levels to a certain extent. But regarding oxidative stress, off the top of my head, I'm not entirely sure which markers those are. So you're stumping me a little bit here. And I'm not sure if Merck Health offers those because usually, at least from all the labs that I visited in my years, I never see specific markers for oxidative stress. In all the studies where they mention that, it's all highly specialized lab equipment where they can actually test that. Yeah, so unfortunately, I can't answer that question. Sorry.
High sensitivity C-reactive protein would be just by looking at inflammatory levels would be a good
Yeah.
proxy.
So that has nothing to do with oxidative stress, but if you're in a high oxidative stress environment, your inflammatory markers can go up also. But then it's already too late, right? So you're trying to prevent that. When CRP is elevated from carrier oils or processed foods or environmental pollutants or living at high altitudes, again, I have an entire deep dive about systemic inflammation and carrier oil on my YouTube channel. There's multiple reasons why they can be elevated, but the low-hanging fruit is either the carrier oil, the diet, or some sort of environmental pollutant. And oxidative stress is maybe one of the reasons why inflammatory markers go up, but then you really need to be oxidized for that to go up. So as an example, let's say you take all antioxidants out and you run a marathon on steroids. I think your C-reactive protein will not be that substantially elevated compared to eating something that's highly inflammatory or getting some sort of disease that is also highly inflammatory. So I would preferably test that separately if possible. And otherwise, again, staying on top of your antioxidants, vitamin C, ubiquinol, N-acetylcysteine, injectable glutathione, taurine, boron. I mean, there's so many antioxidants, vitamin E. It's even estradiol is an antioxidant in the endothelial tissue. So, right, there's more antioxidants than you might realize.
We have one from another anonymous attendee. Does Telmisartan aid in lowering hematocrit? I know this has been reported anecdotally. I'm not
Yeah.
sure if there much literature on it, but I'd be curious your thoughts or any.
So it keeps hematocrit favorable, assuming you don't overdo your testosterone replacement therapy. And again, telmisartan or enalapril, which is far more potent, that actually lowers hematocrit quite substantial. That's enalapril. Telmisartan might modulate it favorably, but if you have sleep apnea or you take steroid cycles, then I see in many cases that hematocrit might be lower without it, but it might still not be in range. And again, so you have some educators on the space. I take Telmisartan and you never have to donate blood, regardless of how much steroids you take. That's a blanket statement that I would not follow. Again, go with your blood work parameters. If you get a beneficial effects of hematocrit, if you take Telmisartan and you add that in, great, good. But this is not the reason to take it. This is a welcome side effect, just like blood pressure management is a welcome side effect of tadalafil, even though that's what it's initially been investigated for. You take Cialis tadalafil to improve erectile quality, and if you get blood pressure management out of it, win. Now I don't need two medications, I get one medication, two results. And with telmisartan, right, you take it as a blood pressure medication, and if you get increased erections as a side effect, and you get hematocrit under control as a side effect, then you have, well, three, right? Three results. And if you get fat loss, which is to be debated, four results. So there are, two to four. There might be something to say for telmisartan over Cialis, even though I do like Cialis more. Yeah, for its obvious reasons.
Question from Dr. Stephen Horwitz out of Texas. Any reason for someone over 60 to try HEG monotherapy? And I'm curious if you have any general thoughts around age range with things like enclomiphene or HEG, and just age-related testicular decline, if there's going to be a change in
Right.
effectiveness.
So, of course, testosterone production declines with age, but it highly depends on the state of health of the individual. Like, I've seen blood work results of 60 years old where testosterone is 600 nanograms per deciliter because they've been active their entire lives and they kill it. And they're like, yeah, I feel old. I think I want to try some TRT. And they go in for blood work and clinically they don't need it, but they might still proceed to give it a try, right? They heard all the benefits. And regardless of serum testosterone levels, they go through the ringer, try HCG monotherapy first, and now their testosterone is 800, just like mine, because they never touched anything. I think my levels could have been higher, but I, had pituitary and testicular shutdown for a decade. And even then, my testosterone levels came back up. So it really depends on the individual. Like, let's say he's 60 years old and his testosterone is 100. Are you going to make him suffer from 100 to 300 nanograms per deciliter? Is that really going to improve his quality of life? Whether that's HCG monotherapy or enclomiphene or clomid or kisspeptin 10 or granulorelin. I mean, there's so many methods out there. And in my opinion, kisspeptin and granulorelin doesn't really work. So that's why I didn't include it in the presentation. So it depends on the starting point, right? You can always give it a try, discuss it with the patient. And if the patient said, yes, you know what, let's give it a try, and the outcome is unsuccessful, then the alternative is TRT, which isn't a bad alternative. So there's always multiple options. But yeah, it can work, it can't work. It depends, unfortunately. No blanket answer there. I wish there was, but there isn't.
This question's for me. I'm just going to cut the line here for a second.
Oh yeah, cut it in. Let's
I'm
go.
curious, you have decades of experience coaching as an educator, as an independent researcher. What's your process like in terms of picking a topic that you want to really dive into? Like, what does that look like in terms of how you've managed to acquire so much knowledge and expertise?
So I've been basically like trained in research on how to piece things together, right? That was what my university degree was about, like piecing things together, but from a business perspective. So if I learned anything in school, it's that piecing shit together. But I always been curious about how stuff works. So I would take stuff apart and try to put them back together. So I destroyed many a radio and computer back in the day. I was an avid player with Lego and built my own Lego city. So I know how to put stuff together, basically. So if I have a topic that I'm interested in, I go down the rabbit hole and I piece it together. And whether that's with my experience or other people's experience or the scientific literature, right? I think everything holds value. I'm evidence-based, but also experience-based. And if my experience overrides the scientific evidence, then I'm going to go with my experience because that's real world. And the scientific evidence, in many cases, it doesn't play out, or it's manipulated. Right? It's unfortunate also. Like resveratrol studies, I mean, talking about manipulation. Oh man, it's scientific evidence, but it's all manipulated by David Sinclair. So, right. So sometimes you have to take the scientific evidence with a grain of salt and learn as much as you can from what you can find on PubMed, Science Direct, Google Scholar, Research. What is it? Yeah, ResearchGate, and other publication websites. I put it all together. I'm one of the only, or one of the few YouTube channels besides Derek that actually reviews more than one study at a time. I review all the studies on a particular subject and then make a video. Not make this study shows that blah 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 blah, and then I read the abstract. No, I read all of it. That's why it takes long, and that's why my videos are over an hour sometimes. So I just reviewed all of the scientific literature on oxandrolone and made a video. And I did the same for Primobolan, and I did the same for halotestin, right? So I'm very curious when it comes to collection of information. I put everything together, and then once it's together, I form a conclusion and make a video about it. And then after that, I never have to make a video about it again because it's all there. Yeah.
Another anonymous question. What's been the biggest paradigm shift in your own thinking and perspective since you started making content and videos originally?
That's a good one. So again, I always call myself like a stupid meathead, especially my YouTube starting days. Like I started on YouTube about 10 years ago, right? Because I wanted to document my life in Thailand, and then coaching took over. And I thought it was more financially feasible just to take coaching because AdSense and YouTube revenue didn't exist back then. So you would advertise. And since I got 50 clients in no time, I decided to go that direction. So a couple of years later, I decided to get back on YouTube. And when I got back on YouTube, I was just hardcore bodybuilding. So I thought everybody that watched my channel was a hardcore bodybuilder. That's why I said HCG can downregulate you because it's in the context of taking actual steroid cycles. And now I realize that no, the audience is also guys into business or general health or hormone replacement therapy guys, right? Or just guys that are trying to optimize their quality of life with, advice that I can give them. So I realized that my audience is a lot broader. So that means that, I make content for, I don't know, different groups of people. And always try to mix in the bodybuilders because that's my core audience. I love bodybuilding, even though I don't look like a bodybuilder now. At one point, my wife will be pregnant, and then bodybuilder Steve will come back. But the protocols won't be as crazy as they used to be because now I'm not living for myself anymore. I'm living for my wife and a future child. So that chapter of my life is kind of closed. And now I'm way more health conscious, but also more understanding that not everybody is interested in this hardcore bodybuilding stuff. You might want to be interested in parts of it. So I digest it down and make it easy to understand for everybody. Right. So now I have MMA fighters following my channel, Olympic athletes, strongmen, powerlifters, CrossFit, man, so many different classes and hormone replacement therapy guys, right? Or even young guys. When I went to the Mr. Olympia or Swiss Symposium where we talked, a lot of younger guys that watch my channel thinking that they're ready about PEDs, and then they watch my content, they're like, you know what? I'm gonna wait a couple more years. So this is also good to see that I can deter some younger guys from making that leap. And when they do feel ready, then at least they watched hours of content and they probably had a crash course because I didn't have this opportunity, man, to watch a channel like mine. I had to learn it the hard way. So I'm giving back for you guys so you don't have to. All you have to do is sit through a couple of videos.
Phenomenal. You have time for like two or three more?
Sure, man. Yeah, yeah. Keep them coming. I do
Um,
I do 2.5 hour podcast live Q&As on my YouTube channel. So I can last all day, man. I can do this all day.
well, speaking of like cognitive stamina, Dave asks, I'd be curious to see protocols that you combine with keto dieting, specifically nootropics to maximize brain activity and productivity.
Yeah, so ketogenic diet is the foundation of that. I think I started the ketogenic diet when I was 21, or give or take that time, because I always got terrible blood sugar fluctuations and cognitive issues doing like high carbohydrate diets. And even though high carbohydrate diets are the best for bodybuilding, right? Ketogenic diets aren't really the best for performance and endurance and stamina. They are very good for cognition. So I've been in a ketogenic state for 15 years, give or take, besides on holiday, and then I eat carbs to my heart's desire, right? I eat whatever I want. But the majority of my life I've been on a ketogenic state. So, healthy protein, healthy fats, and vegetables with some fruit post-workout, allowing me to be highly cognitive most of the day. Then I have an entire YouTube series dedicated to optimizing entrepreneurship in the context of taking nootropics. And of course, there's several levels in nootropics, right? We have the over-the-counter supplements. Gorilla Mind has several great formulas. Like Gorilla Mind Respawn is one of my favorites. It contains alpha GPC and a little bit of caffeine, uridine 5-monophosphate. I think it's L-theanine and saffron extract. And putting all of that together increases cognition, memory recollection, focus, but also channels that in a certain direction, because caffeine can be quite stimulatory, and then L-theanine kind of channels that in the right direction. Now, if you start combining something like that with stimulatory nootropics like DHEA or bromantane, right? All these things are probably not prescribable, but people are using them. Ritalin, modafinil, all that kind of stuff. Then you kind of have to see what works best for you. I took low dose modafinil for a very long time, 50 milligrams per day. But since there's no clear fertility data on it, and I think it's even been shown to be negative on fertility, I decided to take it out. And then after coming back from the United States, and I need a little bit of boost from the time zone, okay, 1 or 2 days modafinil, done, right? Done. But I really like modafinil. I like DHEA. I like Noopept. And Gorilla Mind Respawn or a homemade combination cocktail of alpha GPC, uridine 5-monophosphate, and L-tyrosine, that usually gets a day going quite well. And then if you're in a deep ketogenic state, I can literally work for hours at a time. Yeah, literally work for hours. But I work from home, so that helps also, right? I have no distractions. Not everybody. I don't think I'd be working like this focused if I was in an office environment where people would be walking around and, you have meetings and things and breaks, and like I can structure my day as efficiently as I want. Yeah.
Just the 7 cats just walking around.
Yeah, so that's my day break. Yeah, for the guys that don't know, I have 7 cats. They're all Sphinx cats. They're as bald as I am, and I wake up at 12 o'clock in the afternoon, so that we usually have playtime for about an hour there after their lunch. Then they go to bed to about 6 o'clock in the evening, and then for 5 hours straight, I just grind. That's when I record my videos. That's when I script. That's when I do research. And then when the cat wakes up, I get my little mini break, and we have another pet session. And then I do some consultations. I go to the gym and do some more research in the evening. Yeah, that's basically my day, 6 days a week. So if you think that self-employment sounds good, 6 days a week.
Phenomenal. On the keto topic, Richard says he was on a keto diet for 3 years. He would cycle off periodically and experiment with targeted keto, but SHBG was always 90 to 113.
Yeah.
Got off keto, dropped significantly, but still floats around 60, 70. Also had high cortisol that would not metabolize efficiency, as shown by a Dutch test. Tried
Okay.
boron, Funcat, Fedoja, etc. Doesn't seem to go down. Honestly felt my best on keto aside from the free test being crashed. Any advice on the SHBG? I'm going to assume he is not on any exogenous hormone replacement by
Yeah,
the.
yeah. So this is a known side effect of the ketogenic diet and the carnivore diet, that SHBG levels just go sky high. And it's the same with fasting. If you fast drug-free, your SHBG might be 130. So there's something about restricting calories and something about reducing carbohydrates that really sends your SHBG levels high. And you can take 12 milligrams of boron, and it doesn't come down. It doesn't come down. There are some compounds out there like metformin, for example, which is known to increase SHBG levels to a certain extent. And if you take metformin on a ketogenic diet, it might be even higher. And then if you want to suppress it, you take the metformin out and you take boron, it might not come down. So what I see in most cases of, otherwise drug-free people with high SHBG levels, and you tried all of the over-the-counter supplements already, in this context, you can actually try a low-dose proviron, 6.25 milligrams once per day, check your blood work parameters of your SHBG, your LH, your FSH, your total testosterone, estradiol, your lipid parameters, because those might all be affected. But in a lot of cases, 6.25 milligrams proviron is selective enough to only inhibit the SHBG, reduce that over time, free up more testosterone, improve your libido with no negative effect on luteinizing hormone, follicle stimulating hormone, total testosterone, estrogen, and even lipid parameters. Like I think the Proviron has, I might be misquoting it, but I think it's like 600% affinity for the SHBG compared to dihydrotestosterone, where all other steroids have a lower affinity for the SHBG. I just made a video about it, but I can't. I mean, I remember these numbers that I quoted, but I don't remember the affinity. It's significantly higher than anything else. So if Proviron, you take that and it all occupies the SHBG and not the androgen receptor, or it can inhibit the aromatase enzyme to a certain extent and lower the conversion of testosterone into estradiol, which is favorable because estradiol is one of the suppressive hormones on your pituitary gland, which if estradiol levels are high, LH and FSH levels go down and thus testosterone levels go down. So if you inhibit the SHBG, increasing testosterone, and you inhibit the aromatase enzymes, lowering estrogen and increasing testosterone, LH and FSH levels might be totally normal, and you have a net outcome of having phenomenal libido for a quarter tablet a day, which is very inexpensive. Again, blood work before and after, because you are taking an anabolic androgenic steroid exogenously, and not everybody will respond to this protocol favorably, but I've seen it work more often than not. Yeah.
With that, I'd be curious, seeing lab work from ketogenic individuals, sometimes you see, even though their fasting insulin is very much within an optimal range, their A1C sort of creeps up into that pre-diabetic territory. Do you think that that's indicative of anything pathological underlying, or is that just more so noise than signal?
It could be like glucose homeostasis is regulated by multiple things. So estradiol contributes to glucose homeostasis, micronutrients contribute to glucose homeostasis. And if you follow a ketogenic diet and you're missing essential nutrients, which help with insulin sensitivity, magnesium and vitamin D3 being some of them, then yes, your hemoglobin A1C might go up because serum glucose levels go up because it's not being absorbed by skeletal muscle. And again, if you do a ketogenic diet, doesn't mean that lowering your carbohydrate intake is automatically going to improve your metabolic parameters. Activity still, contributes. So you still need to do some cardio. You still need to do some exercise or some walking in between sets. And if you then still see that your glucose levels go up, your hemoglobin A1C levels goes up, maybe you get a lot of gluconeogenesis. The liver converts protein, especially whey protein, into glucose. So whey protein, BCAAs, essential amino acids, are inherently insulinotropic because leucine and isoleucine convert into glucose the most, and thus have a little bit of insulin release. And if that happens chronically, you're eating like 400 grams of carbs and no vegetables, right? Because this is one of the faults of the carnivore diet. You're eating 400 grams, sorry, not carbs, protein. You're eating 400 grams of protein and no vegetables, so slow the digestion. You're metabolizing some of this protein into glucose, and now your glucose levels goes up, and you have poor glucose homeostasis, increasing your hemoglobin A1C. And the saturated fat in the animal meat sources is ruining your insulin sensitivity. Then yeah, serum glucose levels will be elevated, and you might even give yourself non-alcoholic fatty liver disease, even though there's no scientific evidence to back that up. I have seen carnivore guys with non-alcoholic fatty liver disease. Yeah, not naming any names, but it's pretty bad.
Awesome. Well, where can people find you?
It's very easy. You type in Vigorous Steve on YouTube and you find my channel. And it's the same for Instagram, Vigorous Steve there, vigorsteve.com if you go on Google. And I even have a TikTok, but I believe that that's not around much longer.
Yep.
So if you want to follow me on TikTok while it's still around, Vigor Steve there as well. Thanks so much, dude. It was a lot of fun.
Yeah, likewise. Thank you so much for your time. For everyone who still has questions, please reach out to our team. We have a whole network of partner providers that would be happy to meet with you, answer any questions you have. And then I saw a lot of questions lastly about where they can see the slides. So I'm pretty sure, Steve, you're going to be putting this up on your YouTube here pretty
So,
soon.
so I got all the citations here, right? And I'll add a few more. What I'll do is I'll combine all of the slides and the high quality recording, and then I'll drop that on my YouTube channel sometime next week. I'll put all the citations down below in case you want to do additional research. And then, you know, if you watch that video, just ask me some specific questions on the Vigorous Q&A, which is always on Saturday. So I'll do that tomorrow around this time. And then once the video dropped and you have additional questions, just join in Saturday. It's, well, this time I'll be live, and then you have 2.5 hours to get your questions in. But there's a lot of people and a lot of super chats. So, yeah, be ready for some, yeah, some herd mentality. It's a lot. It's a lot. Yeah, but I'll do my best to answer your questions regardless.
Phenomenal. Thank you so much. Thank you so much, everyone, for attending.
Thanks, guys. I'll talk to you soon. Peace out.